Good morning, Dr. Rasouli.
Hey, good morning.
How are you?
Doing great. Let me go ahead and share my screen.
Perfect. People will just join. Usually about 9 o'clock, everyone's here.
Do you see this as presenter view, or do you see this as just one slide?
We see 2 slides.
Okay, hold on one second. Change this. How's that?
Yeah, that's good.
Okay.
You can begin if you want.
Okay. So I'll go ahead and start. All right. So good morning, everyone. Great to see all of you back again for my, I guess, part 2 of my Brain Turns talk. Based on what you guys were talking about last time and some of the things you wanted me to talk about today, I kind of changed my talk to kind of address those things. So today we're going to be talking about a little bit about how I got interested in neurosurgery and my path into neurosurgery and fellowship and how I became an attending. And we'll talk a little about spinal trauma and tumors too. So if I'm going to kind of focus the bulk of my talk on my path into neurosurgery, and then talk a little about spine trauma as well. I think a lot of these things are going to be hard to cover in one day. There's just so much to talk about, So a little bit about me is kind of the structure of it. A little bit about me, where I grew up, where I'm from, my college and med school, how that I kind of got interested in going to med school, how I got interested in becoming a doctor. Then what, just residency, the way that's structured, the way you apply, the way some of the things you're going to look for in your application when you're applying from medical school to residency programs around the country. And then I did some cool cases, and we'll just kind of go on a little bit about it. So this is me. I was born on May 9th, 1986. So you can see how old I am. I'm giving that away right now. My family initially lived on the Upper East Side of Manhattan, right there on 87th and 3rd Avenue. My building is still there. And if you guys are ever in town and you want some good places to go to eat, these were 2 places that are fairly close to me. This is, in my opinion, one of the best burgers you're going to get in Manhattan. This is J.G. Mellon. It's a little bit south. It's on, I think, 73rd and 3rd Avenue, but one of the best, still there. And then this one was very close to me growing up. It's called Papaya King. Best hot dog you're going to get in New York City. Really, really one of the best. So this is if you want the best burger, J.G. Mellon, best hot dog, Papaya King. So that's super important. Then when I was around 6 years old, my sister was born, and our apartment was a little bit too small for the 4 of us. So we moved to New Jersey, and we basically lived there ever since in North Jersey. I went to school at Alpine School. It's in Bergen County. It's about 45 minutes away from the Upper East Side of Manhattan, about 30 minutes away from the George Washington Bridge. And then I did my high school at the Bergen Academies in Hackensack, New Jersey. And this was a high school that had within its one academy had multiple different academies inside of it. So I was in AMST, or the Academy for Medical Science Technology. So kind of in high school, I had an early interest in going in medicine. And I had an uncle who was a cardiologist who took me kind of under his wing. He showed me his office, what he did for work. He saw patients and did diagnostic tests. I really liked that. And I thought that I would kind of explore that a little bit in high school. So ideally, I could maybe tailor my college experience towards ultimately going to med school. But the thing was, when I applied for colleges at the time, I don't know if these still exist now. I'm pretty sure they do. Just shows you how out of the loop I am. There were programs that were called essentially they were called high school to med school, where you would get early acceptance into the med school. So it was an 8-year program at Virginia Commonwealth University in Richmond, where I went. And you basically did 4 years of college, and then you were guaranteed acceptance into their medical school for another 4 years. And some of them are 7 years, like you can do 3 years of college, 4 years of med school. Mine was 8 years. So I was very fortunate. I got into this. So I decided to go there. And this was in Richmond, Virginia. And it's just kind of a picture of downtown Richmond and the campus. It was a nice place. It was very cool. It's changed a lot since I started college in 2003. Back in the day, there wasn't really, Richmond was still growing, it was still developing. There wasn't really, frankly, to be honest, there wasn't really too much to do. But now it's really changed a lot. So it's really a great city. I try to go back at least once a year, see some of my friends if possible. But the thing is, I'm from New York City originally, and it's hard to leave that bubble. So when I was reaching my junior year, I kind of thought to myself and said, hey, I really like Richmond, but I really wanted to be back in New York. So I kind of took a gamble. I went back on my acceptance on the guaranteed program, and I ended up taking the MCAT and applying for medical schools. And I was very fortunate in that. I was going to skip that. I was very fortunate that I was able to get acceptance into Albert Einstein College of Medicine. So I just want to give you a little bit about the MCAT for those who are about to take it, or are, I guess not so relevant to the medical students, but it's probably changed a lot since I've taken it. So I took the MCAT back in 2006. And at that time, it was only offered twice a year. It was a written test only. It was only offered in April and August. That's it. And then generally you want to take it in April. That was like the best time to take it. If you took it in August, you were kind of behind the curve for the application cycle. And you generally took this in your junior year. Now it's changed a lot. I think the grading has changed a bit. I think the sections have changed a bit as well too. So this may not be relevant at all anymore. But this is so much better for your flexibility on when you want to take it. Back in the day, it was only offered twice a year, which is very, very stressful, as you can imagine, because April is right in the middle of college and your classes and everything. It was very difficult. Again, this probably changes, but the magic numbers at the time were a GPA greater than 3.5 and MCAT greater than 30. This is like kind of what you want to shoot for. This was if you could get this, if you could kind of land this, you had a very, very good shot of getting interviews at different medical schools. And once you kind of get your foot in the door for interviews, you had a very, very good shot of getting in. So I went to Albert Einstein College of Medicine. That's in the Bronx in New York. So it's a, medical schools are 4-year programs. The first 2 years are mostly didactic, with the second year being a little bit more clinical. And then after your second year, you take the USMLE Step 1, which is arguably probably the most important test you're going to take other than the MCAT in your entire life. This is super important. The residency programs place a lot of weight on this. Not so much like they're looking at, they just want to, there's not like a true cutoff, but they put a lot of weight on this in addition to all your other accomplishments in medical school. But this can be a game changer for you. If you do very well on this can really open up a lot of doors. Then your third and fourth year are pretty much all clinical. So you're going to be rotating to different specialties. You're going to be, essentially getting out there in the real world, working with people. I would say in terms of your interest in, let's say, neurosurgery, for example, very few people I met, although I think that's changing a lot, but people that I met, very few people when I was in M1 knew what they wanted to do as they were, it was really only until they were progressing through medical school that they kind of ultimately fell into their path. Now, I kind of got interested in neurosurgery around here in my third year. I was fortunate in that I rotated with the neurosurgery department at Montefiore Hospital in the Bronx. And I really, really had a great experience with them. And that really sparked an interest for me to go into neurosurgery. It was really here in my M3 year. When I started medical school, I was actually studying cardiology because my uncle, I kind of just being with him and through the family, I was just interested in cardiology. I thought it was pretty cool, but it was not until my third year that I got interested in neurosurgery. Now, I will say that, we're seeing applicants who are very interested in neurosurgery much earlier, like even in college, which is kind of unbelievable to me. But yeah, it's true. So I would say if you are sure you want to do neurosurgery around your M1 or M2 year, the best thing you can do is try to rotate with the department, do some little things here and there, and try to get involved in some research projects with them and stay connected with that department. That's going to be key. Sometimes medical schools may not have a hospital that has a neurosurgery department affiliated with them, which is unfortunate. But if that's the case, then you should contact, I guess, the nearest neurosurgery department and kind of try to work with them from a distance, try to do some papers. It's very difficult if your medical school doesn't have a neurosurgery department affiliated with them. That's increasingly rare. So you apply for residencies in your fourth year, and that's the entirety of your fourth year. Essentially, you're going to be applying to different residency programs. They're going to be doing a lot of interviews, and mostly that's in the beginning of your fourth year. So by January-ish, you kind of are tying it up, and then match days in March. So that's when you're going to have your big day. Now, sometimes there's a lot of debate about USMLE Step 2. You're going to have to get these done before you graduate. I will say that, the CK is a written portion, the CS is the clinical portion. I will say that I think the USMLE Step 1 is a pass-fail test now. So this has kind of changed this dynamic. Back when I was taking it, if you did not do so well in the Step 1, you wanted to take the Step 2 CK early. So if you could do well on this, it kind of negated your Step 1, which is good. If you did very well, you may want to put this off. That was kind of the strategy there. I think that's all changed now. I think maybe now, because USMLE Step 1 is pass-fail, you may want to take Step 2 CK earlier. So I liked cardiology. I was really interested in that, but ultimately I decided to do neurosurgeon. And the reasons for that were that when I rotated with that department, I was kind of blown away. And I really liked how challenging the patients were. They were very complicated. You worked in the ORs were so high tech. It felt like something out of Star Trek. You went in, I was so blown away by like the brain lab and the stealth. I had never seen anything like that before. I thought it was so cool that you could, hold a probe to the head and you knew exactly where you were and it synced up perfectly with the MRI or CAT scan. That was super cool. I can't really think of too many other surgical specialties, maybe ENT, that does anything similar to that. And I just really liked how the field was growing with technology and not getting replaced by technology. So as the technology got better, we only got better. It wasn't the technology was going to replace us ever. It was obviously, some of the surgical things, you're helping people, you're working with your hands. It just seemed so interesting. And I'll be honest, I wasn't even really a fan of my neurology course in medical school. It was all right. I wasn't blown away by it. But it wasn't until I worked with the neurosurgeons that I really saw what they did. I really, really enjoyed it. It was just so different from anything I've ever done before. So I would really advise to get out there and rotate with them. Really, really rotate with them. Do like a week or 2 weeks. Just see if it's for you, because you want to see if not only is it the field for you, but the lifestyle has to be for you as well too. And I would say that's the major thing that can be a detriment. It's just how challenging it can be to get a good work-life balance. But it's very doable. It's very, very doable. So neurosurgery in general can be broken up to a bunch of different subspecialties. You have brain and spine tumors, open and endovascular, pediatric functional spine, peripheral nerve. I was initially interested in functional neurosurgery, but eventually I kind of migrated over to spine when I started doing more of the complex cases and doing more scoliosis and adult spinal deformity, which is the bulk of my practice now. So what we're looking for are applicants and trainees and neurosurgeons who are altruistic, have extreme attention to detail. I'll say this is probably the most important thing right here. Super, super attention to detail. Very hardworking. Have integrity, honesty, and are good problem solvers. If you have these, it's simple. If you have all these things, you're a great advocate, right? Very simple. Anyway, so the problems with it, I would say the main things that can be a big deterrent right off the bat. It's the longest residency program. It's 7 years of your life. Usually most of these programs have one dedicated research year. The working hours can be very long and can be very challenging. And you're often working in an environment where you have a lot of patients. You don't have many people who who know the same level of or have the same understanding of the patient and the neurology and kind of what needs to get done as you do. And there's a lot of expectations and managing expectations among all the different attendings and the patients and your coworkers. It can be very difficult. The patients, again, I said one of the benefits was challenging complex patients. One of the negatives is challenging complex patients. Every patient is very complicated with tons of things going on. ICU, this and that. It's very hard to find a patient who's quote unquote easy and straightforward. There's always a twist. There's always something. I mean, I love that, right? But it can get a little bit exhausting. like I said, you're always understaffed. There's just no way of really solving this, I think. And then, it can be very stressful. So these are, again, it's all about how you manage it. And, sometimes people, you will find a way to make this work for you. And these should not be, I should kind of get rid of that term deterrence. These are just some of the things that make this challenging, because you're going to find a way to make all this stuff work for you. Because if you truly love your job, all these things are not even going to matter. You're not even going to work a day in your life. You know what I mean? So I showed this before last time, because this was a funny thing that came out when I was in medical school, and it showed some of the stereotypes of all the different specialties. And I really liked the neurosurgeon one because I thought it was pretty accurate. It just, you'll see when you're attending, you're gonna turn into this, But what I thought was funny was the bubble with this like heart, loving himself despite all this stuff, So anyway, so I went to Mount Sinai for residency. I interviewed at essentially most of the programs in the Northeast. I did my sub-Is at Montefiore, NYU, and Columbia. All three of them were in New York City. I really wanted to be in New York City. That was my main thing. And people ask, oh, should you spread them out? Should you go where you were at? I would say it doesn't really matter. Unless there's unless you're in. See, I was fortunate that in Manhattan you have 5 neurosurgery programs, right? You have, or even more than that actually. You have Mount Sinai, you have Cornell, you have Columbia, you have NYU, Monty, Lenox, or Northwell. You have UMD&J, right? Just in that small radius, you have a huge number of neurosurgery programs. So I didn't really have to leave. But you may be in a place where you only have 1 in the whole state, right? So then in that case, you're gonna have to do about 3 or 4 sub-Is, I'd say. The letters you get from the sub-Is and the connections you make at these are gonna be one of the most important. This is what they're gonna look they put the most weight on this. I'd say, yes, your performance in medical school and other rotations are gonna matter, but the most important things are your sub-Is, your performance on interview day, right? How you come across the attendings and the residents. They're gonna have to see, hey, can I work with this person for the next 7 years? That's gonna be super important. And then your research. These are gonna be these are the most important things they look at. So I applied. I did my sub-Is in New York. They did ask me about that during my interviews. I interviewed all over the country. And they did ask me about this. So it sounds like you only want to be in New York, right? So that's something I had to explain. I said it was just much more, these programs were very good. I knew people there. They wanted me to rotate there. But I was very open to going wherever, they would take me. You just have to be something you have to explain. But anyway, I'm spending too much time on this. So interestingly, I did not do a sub-I at Mount Sinai, but I matched at Mount Sinai, right? So that was kind of interesting. So I liked my interview day at Mount Sinai. I loved, what actually stood out to me the most, more than anything, was how closely knit the residents were. They were awesome. They were super cool. They got along really well. I had never seen any program like that. They were just like a bunch of friends, and they seemed they worked very well together. Everybody was nice. Everybody showed up to the interview dinner, which was important to me. That's actually a big red flag, by the way. When you're an applicant and you go to the interview dinner, typically held the night before, because I think now they're doing these more now. I think they're going to be transitioning away from Zoom and kind of going back to the more traditional interviews. The dinner the night before, if only like 2 residents show up, that's a huge red flag for the program. So just FYI, if you see that, that's not a good thing. You really want to see a lot of a lot of res there, and you want to see how they talk about the program, how they mingle with the applicants. These are all things you want to look for. These are subtle things. So interview day was great. I really enjoyed it. I really liked the department. I liked where I was. I liked being in New York City. You see, that was very important to me. I liked the structure of the program. Everything seemed great. I was very, very happy on match day when I got into Mount Sinai. So Mount Sinai has changed a lot. I started my residency in 2012, and it has changed a lot since I started. A lot of things have changed since I started residency. A lot of things have changed. When I started, I'll tell you some of the big things. So now Mount Sinai Hospital is a huge complex all throughout New York City, and it's spread throughout Manhattan, Queens, Brooklyn. Now they have sites in Long Island. So it's all over this area. When I started, Mount Sinai was just Mount Sinai on the Upper East Side, and now we rotate to a bunch of different hospitals here, which is pretty interesting. I think that's better for our training. Another thing that changed is ACGME and the structure, case logs. That was something I was introduced during my residency as well too, where they're not just looking at the volume, just the absolute number of cases you're doing. They're looking at what kind of cases you're doing, right? How many vascular cases, how many tumor cases, how many functional cases. This was new in my residency. There are a lot of things that have changed as well too with the structure of the programs and what they're placing emphasis on in terms of your training. And I think from what I have seen, most of these changes have been very, very good. These are all the different hospitals we rotate at or have some sort of presence in. It's a big center. So 7-year program, 2 residents a year. A lot of programs now are 3 residents a year, right? Or they somewhere range between 1 and 3 residents per year. But I think they're trying to get more and more programs that have 3 residents a year. So the way my program was structured was you do your first 3 years are junior residents. I think this has changed, right? Your 4th year was a protected research year. You didn't take any call, and you either did an enfolded fellowship or you did a year of research, and you had to have a PI. It was a whole thing. In your 5th year, you were chief resident at Roosevelt Hospital and Beth Israel, this is actually now known as Mount Sinai West. Beth Israel doesn't exist anymore, and Roosevelt is now Mount Sinai West. So you're just chief resident at Mount Sinai West. At 6th year, you're the chief resident at Elmhurst and Sinai, and in 7th, you're like the grand chief of Sinai. And you're basically like a mini attending over there. You run the service, you manage the administrative duties, which are probably the biggest things that you do, and you do cases you do kind of the gold star cases with your chairman, your program director. You get first pick in the OR. So that's kind of the benefit of being there. Now, some of the cases that we did and some of the cases that you're going to do, I still like to this day. So these are tumors, right? This is a meningioma, a convexity meningioma. I showed these before, right? This is a pineal gland lesion. And you can see the difference between the two, how just a slight, a couple of centimeters deeper changes the whole case, right? There, fairly easy craniotomy versus here, much more complicated case, right? You're going to see spinal stuff, cranial and spinal trauma, and just showing going on some of the cool cases I did. So this was a 62-year-old lady, headaches, and loss of fine motor coordination in her right hand, right? And she got an MRI, showed that convexity meningioma I showed you, right? It's just slightly lateral to the falx, right? It does not invade the sagittal sinus. These are some of the things you're looking for. There might be a little draining vein here. See that? These are little subtle things that can really change this case. So this is either enhancement of the dura, or this could be a draining vein. You don't know. You probably have to see it when you get in there. See, this is what's called dural tail, right? There's enhancement of the dura relative to here. Look at the difference, right? All that means that you probably have to resect this. You have to really take out a lot here. And then you can see that the brain is compressed by this tumor. It doesn't look invaded by the tumor. So these are all good signs. This means that this has been here for a long time. It's indolent, slow growing, given her chronicity of her symptoms, right? You see a little compression of the ventricle here, right? So this means that this thing will probably come out pretty easily. I thought this was interesting too. On the CAT scan, you can actually see it, right? It's so calcified that you can actually see it on the X-ray. Oh, this is the scout. It's pretty interesting, right? I thought that was pretty cool. So once we got in there, you can see this is showing you. So we did towels around the head. These are just 4x4s that kind of absorb blood from the scalp. You see we did a circular craniotomy here. We opened up the dura, and this is the tumor essentially just expressing and popping out, which was and it had a very natural tissue plane. We used cottonoids to dissect around the pia and the actual tumor itself, and this popped right out. And this is a neuromonitoring electrode that we use to monitor electrocorticography on the surface of the pia. And that's the tumor itself. It was this little calcified ball. It was about the size of probably about a golf ball, maybe a little larger than that. And it came out very easily. It did not invade the pia. So that was nice. It was a pretty cool case. So this was another case that we did in my chief year. This was a 42-year-old lady who presented with very similar thing: right hand numbness and weakness for several months, word finding difficulty. And that's the MRI. And just kind of curious what you guys think. Why don't you type it in the chat box if you just had to take a look, right? This is axial and sagittal T1 MRI. I'm gonna look at some of your comments while you guys answer some of the questions. What do you guys think? Just based on this, what's the differential diagnosis of this lesion? Awesome. I see one infection. Anyone think this looks like a tumor? Yep. Yeah, I like it. Awesome. Yeah, very cool. So yes, so I agree with all these. Now I want to say a couple of things. Abscess, right? There are three things that one thing I want to point out, you don't see much swelling, right? You don't see much edema around this. There are three things that present with edema out of proportion with the size of the lesion, okay? Small lesion, tons of edema, three things. And the mnemonic is MAM, M-A-M. I'm gonna type that in, MAM. It's meningioma, it's meningioma, abscess, and Mets. Those are three things that can present with tons of edema and a tiny little lesion, okay? MAM, meningioma, abscess, Mets. Do you see a lot of swelling around this? Not really, right? You don't really see much edema at all. So we weren't really thinking infection here. It does look cystic, right? So, and she presented with almost like seizure-like stuff, seizure-like activities. Her symptoms responded to Keppra. They all got better. So, and she's from the United States, so recent history of travel. Anyway, we were thinking to do an excisional biopsy. And the main thing in the diagnosis, the differential was that this was potentially like a small, like a early GBM, maybe an abscess. Anyway, so we did a craniotomy and a small craniotomy right over the lesion. We used stereotaxy to help navigate us to the lesion. So just to show you what's going on, this is a Sylvian fissure over here, right? See this? Has a Sylvian fissure over there. This is just like a cortical artery. You can see, maybe it's, yeah, it looks like an artery. Maybe it's a vein actually, or maybe it's an arterialized vein. I think it's a vein. It looks like a vein. I don't know why it looks like an artery to me right now, but it's a vein. So okay, so then here's the actual lesion itself. It was underneath the pia. We just bipolared it a little bit. We kind of dissected around it, and that's the lesion. So once it started coming out, you can see here, that's it. This is the lesion, right? That's it. We took it out. We plucked it out. And if you can look, right, it almost has this consistency of like a grape, right? So we took it aside, we cut into it, and look what came out. Anyone take a guess what that is? What does that look like? This was a little calcified guy, right? Almost like a grape. We cut into it, and this little guy came out. So this was neurocysticercosis, actually. This was a tapeworm. Yeah. So this is neurocysticercosis. So this patient actually, once we got this out, the patient had complete resolution of her symptoms. She reported a history of recent travel. I guess it didn't really occur to her before, but she had a recent travel to Mexico, and then her symptoms started about 3-4 months after that, right? Right. I'll never look at grapes the same way again. Exactly. So what happened here? So how does this even happen, right? It's not, so neurocysticercosis has two life cycles, right? One is the main vector of transmission is through eating uncooked pork, right? So if you eat uncooked pork, the larva can insist into your musculature and liver and places like that and other organs, and they basically just kind of basically chill there, right? And they can I'm sorry, actually no, I take that back. I made a mistake. No, if you eat the larva from uncooked pork, it will form a tapeworm in your colon. That's what happens. So you eat uncooked pork, you get a tapeworm. If you eat the eggs, which can only happen if it generally will happen through if you have to have someone who has larva on their hands and they prepare something that's uncooked, like salad or something that you can eat raw, and you eat the eggs, then that can insist in your body. That can insist in your liver, in your musculature, and go to your brain. and form a cyst there, and that's called neurocysticercosis. So it's generally treated with an anti-helminthic agent called albendazole. But in this case, this was a bit of a diagnostic dilemma, given that she had no risk factors to have this. It's very, I mean, this is super uncommon in the United States. So, so we took this out. Anyway, we cured her of it. That's the benefit of this. So I thought it was pretty cool. So that was a nice case. I still remember that to this day. It garnered so much interest that they actually interviewed, Channel 7 News interviewed us, interviewed the patient, and it's still up there on the internet. Actually, if you type in my name and tapeworm, it will pop up, so you can see that. So that was just kind of a picture at the end. You can see this is the cavity in which this came out. Okay, so brain aneurysms. These were some of my favorite cases, believe it or not. Even though that I'm a quote unquote spine guy, I thought these were some of the coolest cases that I did. So this was a patient who 7 years old, presented with thunderclap headache and unresponsiveness. She was GCS3, and you can see here thick subarachnoid hemorrhage and a suprasellar cistern extends out to the sylvian fissure on the patient's right-hand side, where there might be a bit of a hematoma, right? And you can see that there's also a nice blood clot here, tons of brain swelling, right? You don't even see sulci, right? Okay, so if you had to take a guess on what's the source of this, well, so aneurysmal subarachnoid hemorrhage, right? Where did they come from? What was the source? What was artery that was affected? Okay, so I see vertebrobasilar junction. No, that would be like a basilar, essentially like a basilar or ICOT. That wouldn't that would be much more thick hemorrhage around the brainstem. But good guess. MMA, that's middle meningeal artery. That rarely that would present with essentially an epidural hematoma. That'd be super rare to have an MMA aneurysm. Junction of MCA, you got it. Beautiful. It's a right MCA or right MCA bifurcation aneurysms. Beautiful. So right here, it was a 5 by 3 millimeter MCA bifurcation aneurysm. You can see it on a CTA, right? It's just coronal and axial views. What's nice about these, you can really what's nice about getting a CTA is that you know, you kind of know what you're getting yourself into before you go for surgery. It's not blind, right? And here you kind of guess that it is an MCA aneurysm because you can see that this hematoma is thickest around that area where the bifurcation is, but it's nice. So I like to do a hemicrania on this patient to evacuate the blood. You can treat this endovascularly, right? But then what happens with this big blood clot here? This creates a lot of mass effect and ICP issues, and it generally is better to bring this patient to take that out. So we did decompressive hemicraniectomy, EVD, and microsurgical aneurysm clipping. So let's see what I did here. So we went in, we dissected the sylvian fissure, we went down to the aneurysm, and this was actually the first aneurysm I clipped by myself. Can you tell I was nervous? This is at 3 o'clock in the morning. Came in on a Sunday. So I thought like this was towards the end of my my chief year. I thought this was like the coolest thing that I've ever done. This was really the culmination of all my training because I had only watched this when I was a med student. It was the first case I ever saw was a clipping of an MCA aneurysm when I was a med student rotating through Montefiore. It was the attending was David Gordon, who's now at Northwell, and the resident was David Altschul, who's now an attending at Monty, and it was Dr. Gordon leading Dr. Altschul through clipping of an aneurysm that had ruptured. I thought that was the most amazing thing I've ever seen. And then there was me doing it with Dr. Kellner at Mount Sinai. I just thought it was just awesome. So a couple things to point out: cotinoids, brain super swollen. Look how red the brain is. This is all subarachnoid hemorrhage, right? And then this is a clip here. This is a temporary clip to obtain proximal control. So there was no flow through this artery temporarily. Then we placed a permanent clip and then take this off. So that's it. So it was a nice case. Now you can see how swollen the brain is, right? And this is where the whole Hunt-Hess grading system came about, right? Hunt-Hess, right? Hunt-Hess 1 through 5. So what's the importance of that? Yes, it is prognostic in terms of the patient's clinical presentation, but really what it was a grading tool or a clinical decision tool to help guide your decision making about when to do the clipping, right? because this was developed before endovascular treatment. So if you had a patient who was Hunt test 3, 4, or 5, this was the problem you were facing. You were going to get into a very swollen, red hot brain, and you have no tissue planes, and to get down to the aneurysm is extremely difficult. So the thought was kind of let these patients cool off a bit, let the swelling come down, and then treat them medically, and then take them for the clipping, right? It seems very antiquated, but we used to actually sit on these patients for a while, let them basically cool down, and then treat them like 2-3 weeks later. In this day and age, I can't even really think of too many patients that aren't treated, their aneurysms aren't treated within 24 to 48 hours, right? I mean, they're taken like right away. So it's very, very different treatment strategy back in the day. And if there were Hunt tests, let's say 1 or 2, you usually took them right away because it wasn't as swollen. So that's how that would work. Okay, so I don't know what that slide is. Okay, so this was a 32-year-old male presented with sudden onset low back pain, sciatica when lifting heavy weights. If you just had to take a guess what this would be. Pretty easy, right? So one of the biggest herniated discs I've ever seen, L5S1, you see that? So he actually, surprisingly, you would think that this would be called equina, right? Given the fact that it occupies the entirety of the spinal canal, right? And you don't even see, I mean, it's essentially complete obliteration. Now with these types of herniations, he did not present with cauda equina, surprisingly. With these types of disc herniations, okay, and you can see the modic changes here, right? There are 2 things to be careful of. One is, because it's so big and so canal occupying, the tendency is to treat this like a microdiscectomy, where you would come in unilaterally and try to take this out. That can be very difficult. So generally for these big, essentially canal occupying lesions, I do a full laminectomy on this. And the reason why is that it gives you much more control over the removing this gigantic fragment. It's much easier to mobilize dura. And B, in some cases, no joke, I've seen this once for these huge lesions. It wasn't here at 5-1, it was actually a 3-4 lesion, okay? We went in, and this was during my fellowship, we went in, look at this massive herniation, right? We went in, we didn't even see it. Where is it? Looking all around, where is this thing, right? Mobilizing dura, then we opened up wide, we couldn't find it. Then we brought in the x-ray, yep, we're at the right level, right? What do you think, if you guys had to take a guess, what do you think was going on? We're at the right level, huge lesion, we can't seem to find it. It was an intradural disc herniation. No joke, intradural disc herniation. So we actually had to open up the dura, go in and take this thing out. Unbelievable, right? So that's and it was just like this, presented very acutely. It was wild. So you have to, whenever I see these big lesions that present like cauda equina-y with a total canal occupying lesion, I always open up the I always do a full laminectomy. So look at the size of that lesion I came out. It was huge. It came out one piece. It was one of the biggest disc herniations that I've ever seen. So this was a patient with a brain abscess. He presented in extremis. He was in status epilepticus, and you can see that this was a brain abscess here. You can see it extends to the dura. There's a lot of inflammatory changes here. Lots of cerebritis and edema around this, right? Remember that mnemonic, MAM, right? Metastasis, abscess, and meningioma, right? Lots of edema around this little guy, right? So we took him for a cranie, which this is actually one of the first cranies I did during when I was an intern. So we pinned. Now actually, now that I'm looking at this, I have more experience. I'm looking at this, and we actually didn't do a good job here. You can see that he had a prior craniotomy, right? But you see the 2 pins relative to the central pin here. This should be a little bit lower. Actually, this was a little bit too high. You can see he's trying to kind of fall out of the pins. I don't like the pin job we did here. This should be a little bit lower here, okay? And I would move this pin a little bit more here. So that would be a much more stable pinning. There's actually a great video on Neurosurgical Atlas called by Dr. Aaron Cohen Goodall that gives you the nuances and the basics of proper pinning in the Mayfield head holder. To this day, it's one of the best, some of the best videos I have ever seen. And I require all my residents to watch it before they do any of my cases, because this is, you won't see a better way to pin than his videos. It's fantastic. I recommend all of you watch this. So we did that. We mobilized the bone, the scalp flap anteriorly. We took off the bone flap, and then we this is stereotactic probe right on that abscess. You can see it. And then once we open it up, you can see it kind of all running out. It's pretty gross. Very different from the neurocysticercosis case, which was well encapsulated. And we drained out, we took everything out. And he did okay. He didn't do so great, but this is another patient who, a 45-year-old, who presented with vertebral artery dissection after getting a neck adjustment, and then developed a pretty large right-sided stroke. So yeah, pretty wild. There's actually a recent case of a patient who essentially the same thing happened. I think she's locked in, which is even worse. So this was her. This was this patient's interval scanning. You see that just progressively worsening infarct, compression. There's some semblance of a midline shift, and the patient was not doing well clinically. So we took him to the OR, did a hemicraniectomy to decompress the brain. You see this is very large craniectomy. And then this is the post-op scan, just showing kind of interval evolution. And what the point of this is really to allow, obviously, the necrotic brain to swell out, but also save flow to the penumbra, the areas which are at risk of infarcting due to ICP, right? There's pressure on that area, and it's going to infarct if you don't relieve that pressure. So that's really what you're trying to do, is save the penumbra. So eventually what we do for these patients, we take them back for cranioplasties. If you leave them alone, this is what they can look like, right? Not in that case. This is a patient who got a bifrontal craniectomy, but in the case of that, it would be like a craniectomy defect. And you want to, generally we take these patients, if it's trauma, I usually wait about 3 months. For stroke, I usually wait about a month. I take them back much sooner. So we got a 3D printed implant. We placed this on that patient a couple months later, and then we closed it. So it was very good. So if these things are appealing to you, and some of the cases I showed you, then neurosurgery is definitely the field for you. I don't discourage anybody from going to the field. I feel like a lot of the deterrents are very manageable and workable if you love what you're doing, and it's very self-selecting. So the fact that all of you are here makes all of you interested in neurosurgery, and I'm sure all these things I'm talking about you just love, and you're like ready to just take this on. And these are all just kind of all the things I talked about before. Some of the newer technologies, doing a lot more robotic and simulation stuff. That was new in my residency. I came out in my 3rd year or so, and it's getting much more importance now. So you're seeing a lot more of that. This was my intern year. That's me in the middle right there. Is all the residents you all graduated now. These are all attendings now, which is amazing, you know. Just us working with our chairman, Dr. Betterson, who's still at Mount Sinai. And then when I graduated, I did my fellowship at the Cleveland Clinic, which was I started in 2019. And towards the end of my residency, I got interested in spine surgery. And at that time, you apply through either 2 different matches for spine. You either go through neurosurgery spine or you go through orthopedic spine, and there's some combined programs. So I applied to Cleveland Clinic. I thought they had a fantastic program. One of our attendings, Dr. Margettis, had graduated from the fellowship there. He had nothing but rave reviews, and it seemed like the best fit for me on interview day. So that was like my number 1 choice, and it was a combined program, orthopedic and neurosurgery. I loved the structure of the department. I loved how collegial they were. It was just unbelievable. So I was very fortunate. I got into the program there. I lived in Cleveland, Ohio for a year. And what's nice about the Cleveland Clinic is that not only is it truly one of the best hospital systems in the world, you know, it really deserves the name. I mean, it's really an amazing place to work. But it just the breadth and the depth and the quality and the quantity of cases that you do as a resident, as a fellow, are awesome. And the autonomy you get there, it was unparalleled, because you're essentially a neurosurgeon at this point, right? So I was working with the residents, I was teaching, it was awesome. It was a really great experience. We work with many different spine surgeons. I did tons of cases. The bulk of it is degen, trauma, deformity. I mean, it was really, really good. It was a great learning experience for me for a year. It was actually so wonderful. I enjoyed my experience so much. I actually stayed on a year as an attending. So my first job after fellowship was as an attending at the Cleveland Clinic. And then ultimately I was recruited to Northwell to help start the deformity and complex spine program at Sinai University Hospital in New York. So that's where I'm at now. Okay, do we have a little time to do this? Let me take a little break right now. There's a lot I covered. So let's see some of the questions, and let's talk about this for 1 second. So how does step 1 pass-fail affect admissions to residencies? So that's a great question. I'm not sure. I think they're still trying to adapt to that. I would say that they're probably going to place a little bit more emphasis on step 2 CK. So that might be a good, the strategy might be to take that sooner. They're probably going to place more emphasis on your sub-Is as well too, and your letters of recommendation. Those are going to be more important. How much chance do you think an international med student has getting into neurosurgery residency, and do international students who get a bachelor's degree in the US have a fair chance of getting med school? So it's certainly more difficult because you have to look at every year there are more applicants than there are neurosurgery residency spots, right? You have more US graduates who are applying and they have spots open. So just based on that alone makes the chances a bit more challenging. That being said, I know many IMGs who have successfully landed neurosurgery residency spots in the United States. Just look at one of my partners, Dr. Nader Dadale. He posts a lot about this on Twitter. I would highly recommend you follow him. He's amazing, great guy. He has great tips and tricks on some of the things that he did into matching into residency. They're going to place a lot of emphasis on your involvement in the lab and doing research with them. So the more you're involved, the more you're kind of a presence, it's gonna be very, very helpful. Other than getting involved in research project, what else can a med student do to increase their chance of getting neurosurgery residency? So research is very important. You want obviously your step 1 and your grades to be good. You want to do well on your rotations and during your 3rd year when you're rotating through peds and psych, all the other specialties. You want those to be good. We like applicants who apply themselves no matter what situation they're in, right? You don't want to just see an applicant who gets an honors in surgery and fails everything. Well, that would be very rare, but let's just say they pass everything else and they do great in surgery, right? What does that tell you? That tells you that's an applicant who only applies themselves into whatever they're interested in, and they don't apply themselves in any other situation, right? That's not a very good, to me, that's not a very good applicant. And to us in general, that's not someone who we place, that's not somebody that's gonna be easy to work with, okay? You wanna do a lot of sub-Is. You want to make a good impression with the department that you're rotating with. You want them to think of you as a medical student as being, wow, this person was super awesome. They were integrated well. They had good teamwork. We felt great with them. They felt like a member of the team. That's what you really want. And if you can get that, usually the attendings are going to go talk to the chief resident and be like, hey, how did this person do? And they're going to be like, oh yeah, they were great. They were awesome. One of the best, most hardworking sub-Is that we had. So you really want to have that's really going to be your way of leaving a good impression. I work in neuro as an ICU tech. Why do you want to be on bed rest if you have a dural tear? So it depends. Magna is a good question. It's kind of an antiquated thing. And it just depends on where the dural tail is. I don't ever put them on bed rest if it's cervical or thoracic spine, because it doesn't make any sense to me. In the lumbar spine, I may do it if I did not feel like I got a good closure, or if I lost a lot of CSF. And the reason being is if you're upright at 90 degrees, you have the effect of gravity, and the lumbar cistern, it collects over there and theoretically puts a little bit more pressure when you're sitting up rather than laying down on that kind of the most caudal area of the fecal sac. If you're laying down, you don't have as much pressure in that area. Now, another reason I put them on bed rest is if they lost a lot of CSF during the repair, they may have a lot of headaches if they sit up. So I just do that for a day, just kind of keep them for headache reasons. If I got a good repair and I didn't lose much CSF, I don't leave them. I want them to walk as soon as possible. I don't even bother. So a dural tear with a good repair is basically no dural tear as far as I'm concerned. And I would just have them walk. So I don't really like to keep them bed rest. It's not good for the patient. The old school way is like 3 days of bed rest with a lumbar drain. But can you imagine? I mean, that's just awful for the patient. I never found that it mattered. And that's one of the nice things about working with different surgeons. You see different techniques and different protocols. So you see the people who do the 3 days of bed rest lumbar drain, they have the exact same outcome as a surgeon who lets them walk post-op day 0, right? And you wonder why they're even doing it that way. So as you learn, so that's the beauty of doing a fellowship and working with other surgeons. Okay, I know every IMG asks about residency and da-da-da. From your personal point of view, why do you think they made it? Some IMGs didn't. That's a great question, Sam. So the question is, why do I think some of the IMGs matched and some didn't, right? Okay, so I will say the ones that I saw matched, and I'll be perfectly honest, were very hungry. They were very aggressive. They really wanted it. They worked hard. They were there from, 6 in the morning until 10 o'clock at night, tons of research projects. They worked with every attending. They were involved in vascular research, spine research, tumor research. They were so involved that you were like, wow. You didn't even know what to do. Like they were just absorbed everything. They were super aggressive, and they really wanted it. Those are the ones who really got it. Another thing, actually, I forgot to mention this. As an IMG, you may really want to consider doing a pre-residency fellowship or PRF. Mount Sinai has an excellent program. And I would highly recommend you guys apply to that. Just type in pre-residency fellow on Google, and you'll find out about it. A lot of their applicants have matched into great residency programs, and it's a great program. I would highly consider doing a pre-residency fellowship. Actually, that would be an excellent thing to do. Is do a pre-residency fellowship. How can someone show interest in undergraduate besides doing neuroscience research and shadowing? So that's great. That's definitely a great step forward, Elizabeth. I would say the main thing as an undergrad would be to your main goal should be to get acceptance into medical school. No, I wouldn't worry so much about getting involved in neurosurgery department. Yes, it's great, but you really want to, your main focus should be all 100% about get into medical school. Once you get into medical school, then everything else can come after that. But your main thing should be getting into medical school. Now, let's say that you want to, anyway, let's just say like you're doing that and you still want to get involved. Research, that'll be the best thing. There's not really too much else you can do, right? There's not so much that there really, you can't do the surgeries and stuff. So most you can really do is probably rotate through the department, brain turns. This is great, and just kind of stay involved with research. That's really the best thing. The main thing they're going to want to see is just get into medical school. That's your most important thing. Any advice, tips on the financial aspect on education? In terms of, if you could be a little bit more specific, in terms of loans, in terms of how to manage your finances, like outside of school. With loans, you have government, you have Stafford loans, you have subsidized, non-subsidized loans that you can take to kind of, get you through college. And then medical school is also very expensive as well too. So that's going to pile on top of it. All of us have loans graduating, right? We're fortunate now that we don't have to pay them back. So it's kind of, we'll see how this evolves. But I think as time goes on, there's going to be an emphasis on kind of either majorly reducing or potentially limiting altogether physician loans. You can see NYU, I think they don't even charge tuition anymore, which is fantastic. It's such a benefit to the students. And I think I see the field heading in that direction where they're being much more open to doing that. Whereas when I was a student, it was like $40,000 a year on top of all the other payments you had to make. It was unbelievable. So, and then everyone came out with like $200,000-$300,000 worth of loans plus your college loans, and then you were being paid basically nothing in residency. So then you had to do deferred loans, right? So you had to put everything on deferment. So that's just gaining 6.8% interest every. I mean, it was just literally it was highway robbery. I have nothing good to say about the way that system was developed. And you can try paying it back, but you're not even paying back the interest or the principal. You're barely paying the interest. You're not paying the principal down. So it's pointless, you know. So it was a horrible situation for us. As undergraduates, is it okay to be involved in research area that's different from the residency that I'll pursue after medical school? Yes. So I mean, yeah, you can do whatever you like, right? But the thing is, if you're let's say you're doing, so take me for example, I was interested in cardiology, so I did cardiology research, right? And then I applied to neurosurgery, right? So the neurosurgeon is going to look at that and be like, okay, you did some research in cardiology, but you didn't do any research in neurosurgery, right? So that's while it's good and it's interesting, they may not really place too much weight on that. Now it depends on what kind of research you're doing. If you're doing like bench side research and you're doing something like more in that area, and it's applicable some way in neurology or neurosurgery, that can be pretty cool. Yeah, if you can talk about it, that's pretty awesome. That's really what they want to see, is like that you took control of that project and you saw it through from beginning to end. That is actually, of all things, the most important. Like you were able to do the research, write the paper, submit the paper, do the revisions, and get that paper published. If you can, that's like, man, if you can do that, that is awesome. That really shows to us someone who can get it done, a problem solver. Because I see a lot of people who have tons of papers and never got published, and it's like, what happened? You know, you really want to see someone who can see that through to the end. Any advice on managing time in medical school? Yeah, that's always tough. It's always tough because you have to study a lot, and when you're studying and you have all the other things you need to do, it can be very hard to manage a work-life balance. I found that when I was in medical school, I found that the lectures were not particularly useful, and I would rely on just watching them on Zoom. I didn't really go to, I just kind of watched lectures on Zoom, and I looked at the lecture write-ups, the notes. That was what was helpful for me, and I just studied at home. Some people found going to class was more helpful. I found studying at home was more helpful, but I found that 4 hours a day of solid studying was the key to just being on top of your classes and not getting behind. What are your go-to pain meds for patient on post-op day 0? It just depends on the surgery itself. I try to avoid opioids as much as possible. If I do, I give a short course. But it really depends on the surgery. It's hard to generalize. Do the hours per week working during residency change? Like more hours at the beginning? No, it's technically 80 hours a week. With sign off and things like that, and they become very, very strict on this. They watch very carefully, very, very carefully these programs. These programs can lose their accreditation if they are over these hours. I can say that as you kind of get more towards your chief year, that it becomes a little bit more lenient, and you're expected to work a bit more versus in your intern year. Your 1 through 3, they're very strict because it has to do with pager call. As an attending, how many hours do you averagely work a week? That's a great question. It just depends on. So I would say my schedule is much more flexible as an attending. I'm not as fixated to the hospital, right? When I was a junior resident, I physically had to be in the hospital from 5 a.m. until God knows when, right? When you're as an attending, I don't have to do that anymore, right? I can come in depending on my day. If I have surgery in the morning, I'm there by 6:45, 7. I have everything set up for me. I come in, I do the case, and then after the case, I can either go home, I can get caught up on notes. I have much more flexibility in my day. I don't have to stay in the hospital as much as I had to. However, the difference is this: when I was taking call, as soon as I handed off the pager and I gave it to somebody else and I left the hospital, I was done. I had nothing. I had no more. I was not tied to the hospital anyway. I just go home, sleep, done, finished. Right. But now as an attending, I'm on call essentially 24/7 for my patients, right? If I operate on a patient, that patient is tied to me. If they have a complication at home on Christmas, I have to deal with that, right? That's my bond to that patient. That's my responsibility to that patient. That patient is a part of my family now, right? So I mean, in a way, right? They're like a part of my family now. If they have any question, anything happens to that patient, everybody comes to me, and that's what I loved about it. Some people may say, "Oh no, I don't like that." I love that about neurosurgery. That the fact that these patients, you know things and you become related to the patient in a way that's just unbelievable, and that's a beautiful thing about our field. It's really a beautiful thing. What's your best way to avoid burnout? That's very hard. It's very difficult. I would say, obviously make sure you're very comfortable with going to neurosurgery. You have to love what you're doing, and work-life balance. You really have to make sure you have to set aside time to do fun things, get out there, and you have to really make it a point to have fun and decompress and not do work. It's very hard. You have to think of that as, you almost have to schedule that. Like, okay, from 6 to 8, I'm gonna just relax. Literally, that's the best way of doing it. Spinal cord stimulation, optimal option after surgical intervention, epidural surgery. Yeah, that can certainly be an option. But a lot of Tirth, one of the things I find, a lot of these patients who are who have all these surgical interventions, epidural steroids, and nothing works, are often deformity patients. And if you kind of look at their spinal alignment, they often have deformity that has not been addressed and or corrected, and they do so much better with deformity surgery. That's kind of my specialty, is seeing these patients who've been written off and get spinal cord stims. That I would say 80% of them, from my perspective, 80% of them are deformity until proven otherwise. How much time spent on trauma versus time scheduled cases? Okay, so it depends on where you're working, Elizabeth. Great question. I at Cleveland Clinic, I was at a level 2 trauma center. Oh my God, it was so busy. It was right by a highway and a nursing home. So you can imagine, we got clobbered when I was on call. You get so much trauma there. Now, I don't see as much trauma. The vast majority, I say 90% of my cases are elective. And I like that. I really like that a lot more. Although trauma cases are fun. Are there any public health issues that stand out to you as a neurosurgeon? Yes, many. And that could be an entirely different talk, man. I would say the main ones are, we're in an area of where they're much more focused on reimbursement and outcomes, right? And than ever before. There's a lot more on healthcare utilization and value. These are all the things that are looking at now. Hey, are our interventions working, and are these interventions cost effective, and do they make sense, right? Look at this picture here. Look at all the screws this patient has, right? So you can use titanium screws, or you can do gold plated, hyaluronic acid sprayed, BMP infused screws that, maybe in one study show that they, did something, right? So what's the difference, right? One screw is $1,000, one screw is $200, right? Right now, there's nobody to say that you can use one versus the other. So these are things that they're gonna really, really look into. But that can be a whole talk, man. A great question. All right, I think I'm getting over time.
Okay. Yeah, sorry. It is 10:02.
Sorry, guys.
Thank you so much for your time, Dr. Rasouli.